Scoliosis. Have you ever seen a child with a scoliosis? You can very well imagine how much psychosocial trauma he or she has to undergo when she is having such a problem, especially a bending of a spine, which is actually creating some sort of a hump or bony hump, and she is sort of a or he or she is actually having a problem, and how much stress that would be for that child who is being continuously psychologically bullied by his or her peers. So nowadays we have especially regular annual checkups and programs which are available for the schools, and it's mandatory for the schools to check the children for some form of a deformity such as scoliosis. So we'll be discussing the scoliosis actually. What is scoliosis? As you can appreciate, on the left hand side, this is a normal, straight, healthy spine. And usually on the right side, there is actually unhealthy or curved spine. Scoliosis is actually the curvature of the spine, which is in the coronal plane, that is in the medial to lateral plane, which is usually not possible. The child is actually maybe associated with kyphosis, in which the child is bending forward a bit as well, or it may not be associated with the kyphosis. So what happens is when the child bends forward to pick something up, actually at that time the deformity exacerbates and actually is visible, and that is where then it becomes problematic for the children, especially in the bending movements as well. Sometimes the curvature of the spine is so marked that it is actually creating deformity or a problem even when the child is standing. There is actually asymmetry of the shoulder, there may be asymmetry of the nipples as well, and when you see a child, you can appreciate there's something wrong with this child. There's something, he or she appears to be tilted on one side more as compared to the other, and that is where it's mandatory for the actually children or the school teachers, the school those who are actually running the schools, is to make it sure that these children are picked up and actually taken to a doctor, so that they can be either something needs to be done regarding these problematic curves. So what is important to understand is that when you will have a large structural curve, that will be very easily visible, very much visible from the naked eye. But sometimes what happens is the deformity is so subtle that usually it's not visible. It only becomes evident when the child bends forward. So that's why we have actually annually there is different time frames. There are specific programs in which they ask the children to bend forward and then attach scoliometer over the top of their shoulders, and then they assess the degrees of scoliosis which is present. If there is more than 7 degrees of bending on the scoliometer, that means usually that accounts to around 20 degrees of structural curve. That means that child needs a doctor's attention, and that needs an evaluation by an orthopedic or a spine surgeon. Now, what are the different types of scoliosis? There is plethora of classification available. One way of classifying the scoliosis is as per age. For example, if the scoliosis was present in birth, which is usually marked and very clearly visible, that is termed as congenital scoliosis. Other is when the child starts to walk around 4, 5, 6 years. At that stage, that is where it actually starts to come up, and that is called as the juvenile form of scoliosis. And then there is another called as adolescent or idiopathic adolescent scoliosis. That is when usually a child is 10, 11, or usually female, so the female is around 10 to 12 years of age, or it usually amounts at from 10 to 16 years of age, and 18 years of age is usually the common age for adolescent idiopathic scoliosis. Then there is another way of classifying scoliosis as well. Now that newer classification involves is that there is early onset and late onset scoliosis. Now they have defined it into that early onset means scoliosis is evident before the age of 10, and late onset is after the age of 10. So broadly they have divided the congenital juvenile form into one group, and adolescent idiopathic scoliosis, which is most common, in another group, into a late onset idiopathic scoliosis. Then this is form of scoliosis is also one way of classifying scoliosis, that there is a structural scoliosis and postural scoliosis. The structural scoliosis means the problem is in the structural problem with the spine. There is something wrong with the spine. That is why it is actually bending in certain direction. Postural is, if you look at this, the problem is somewhere else, but actually the spine is compensating for that problem. As a result, it has actually gone into bending. For example, usually the classical presentation and example which can be given is, and a lady comes to you, let's say of 40 or 50 years of age, and there was limb length discrepancy, let's say a 4 or 5 centimeter, and she wasn't really, although doctors recommended to use some sort of a brace or shoes, and she wasn't really using it. As a result, her pelvis was tilting on one side continuously because of shorter leg. And over the years, she says she's having a problems with the back pain. So what is actually, when you get the x-rays, the spine has started to now go into scoliosis, and this is sort of a compensatory scoliosis. And why this happens? Because the pelvis is continuously tilted on one side, because one leg is short as compared to the other, and she's not actually doing anything to make her pelvis straight, because she's not actually adhering to the treatment of Hurey's. As a result, over continuous pressures, as a result, spine has gone into some form of a curvature, and this is classical example of a postural scoliosis. There's a problem somewhere else, there's a problem in the hip joint or somewhere else, but as a result, the spine is compensating in form of a scoliosis so that the patient's posture can be maintained normally. This is called as postural scoliosis. The structural one, as I told you, the problem is primarily with the spine actually, and as a result, in the structural problem, this leads to structural scoliosis. Now, another form of this is a diagram of postural scoliosis. If you see it over here, can you appreciate there is subtle change? Now it looks like very much clear cut spine, but if you see it over here, can you see the bend? Because if you see the two levels of scapula, they're not at the same level. Similarly, if you see the level of the shoulder, this is shoulder left is slightly higher as compared to the right side. So this curve may not be very large enough. As a result, now this is where the forward bending or Adams forward bending text comes in, because when you the subtle abnormalities, when the patient has clothes on, this may not be very much visible. So only and only it becomes somewhere evident when she actually bends forward. And if you see, this right side is actually slightly higher compared to the left side. Similarly, now this is another example where you can appreciate, although if you see the shoulder, there is very little difference, but yes, left is slightly higher as compared to the right. But can you see the curve is mainly tilted in the lumbar region? But if you look more closely, the problem looks like in the spine, but it actually, if you see the pelvis, this is a superior iliac spine, and you see it over here. Can you appreciate actually the tilt of the pelvis? Probably she has limb length discrepancy. Her right leg is shorter than her left leg. As a result, over the years, because there was no compensatory mechanism, the spine is compensated by going into the scoliosis. And this may, when she sits, actually, because the pelvis is straightened up, the spine actually also straightens up, and this compensatory postural scoliosis is actually gone. That is how you diagnose these, because to diagnose difference from structural versus postural is when you know where the real problem is, you sort of rule out that problem out, then spine straightens up. For example, if the problem was in the pelvis due to LLD, when the patient sat, the compensatory mechanisms were not needed and spine is actually straightened out. This is an example of postural scoliosis. But when it comes to the structural scoliosis, the problem is actually in the spine. So whether she's standing upright or here she is actually sitting, actually that does not matter, because the structural scoliosis will still persist despite the postural correction is being done. For example, if you see this over here, this is, if you see it, it looks very much okay, but if you see there is a slight difference, very slightly, the right scapula looks slightly downward, while left scapula is slightly more prominent as compared to the right. So there is something wrong over here. For example, if you see the shoulder, they're almost at the same level. Whatever the pathology is, it's very subtle. So for that, to assess that kind of a subtle abnormality, you have to ask the patient to bend forward and get the view from behind. And can you appreciate now what actually has happened? If you see, there is definitely the right-sided thoracic curve, which is actually causing the right-sided rib hump. Now, problem is when the spine is actually tilted, the ribs also get tilted along with it, because the thoracic cage is attached but posterior to the spine. As a result, what we don't see is the spine being tilted, what we see is the rib cage being tilted. As a result, it becomes very prominent and causes a rib hump on the one side of the body, either at the right or the left. Now if you see this is very clear cutly. You can appreciate there is probably not one, there are more than one curves. This is another curve. This is called left thoracic, and there's a thoracolumbar or lumbar curve available as well. If you see it over here, more than one curve, and this is definitely marked scoliosis. When you will ask her to bend forward, you can appreciate the difference. There is definitely right-sided problem, along with there is some still her pelvis is not exactly line, so there is almost some involvement of lumbar or thoracolumbar curve as well, but that is probably less as compared to the thoracic curve, which has become more marked over the forward bending test. So that is the game over here, that you have to assess. Sometimes the abnormalities are so subtle that you cannot assess with when the patient has clothes on, and only when they reach a certain level, for example at 25 or 30 degrees of curve, that this is the magnitude of curve which actually becomes evident with the naked eye. You have to examine the patient with forward bending test. Now if you see what are the clinical features of the scoliosis. On clinical features, it depends what type of scoliosis it is. If it is the juvenile form or the congenital form or it is the early onset form, usually these scoliosis are more severe. There is increased magnitude of the curve, and usually they are syndromic. They're associated with other pathologies. For example, there may be associated with neurofibromatosis, there may be associated with discrete muscular dystrophy, there may be associated with Friedreich ataxia, or there may be other syndromic problems which may be visible as well. So you have to look at the child as a whole. But if the child or female that has usually come around, let's see, from age 10 to 18 or 11 or 12 years of age, mostly it is always the idiopathic cause of adolescent scoliosis. And when you call it an idiopathic, what does that mean? It means we don't know the exact cause of that problem. But yes, most likely there are different theories related to that adolescent idiopathic scoliosis. For example, there may be a role of a hormone called as melatonin. There may be actually abnormal development, neurocentrodermal ridge, which this is all possibilities or theories which has not been proven, but they say there are multifactorial problems associated with environmental causes as well. But as to yet by this time we call it idiopathic adolescent scoliosis, which means we do not know the exact cause which is causing the adolescent scoliosis. Now, clinical features. There will be definitely obvious skewed back. There will be problems in the back. There will be structural curves which you will appreciate, either right-sided or left-sided curves. There will be the curve, the spine will be quite bending. Then there will be a rib hump in the thoracic curve. And why this happens, rib hump actually happens, is because the spine is attached posteriorly to the thoracic cage. When the spine rotates the ribs along with it. As a result, it's not the spine which becomes prominent, but the rib cage becomes prominent on that side, because when the patient bends forward, this means the spine is rotated in such a way that the right-sided pathology is there, and right-sided thoracic cage is actually tilted because of the tilt of the spine. Then there may be asymmetry or prominence of one hip. You have to assess the patient from the back, from the front, as well as from the side. That is because you have to have a 3D assessment of the spine. And when we say from the back, we have to assess the hip, the knee, as well as the ankle as well, because the normal alignment of the body is also important. There may be a problem with the LLD. Patient may be having standing with the knee bent as well. For example, if the left knee is actually bent and both feet are on ground, this means the right leg is short. That is why the patient is actually flexing the left knee, therefore to make the pelvis straight. But normally when that patient would be standing right up on the left leg, the right leg would not be able to compensate. As a result, the pelvis would tilt towards right. So that is something you need to understand, that we have to look at the whole alignment of the body from the back as well as from the front. And when we look at it from the side, we need to because see, the deformity is not in the coronal plane only. That is something you need to remember, that deformity involves it's a 3D anatomy, 3D problem. There is a coronal plane, like for example, right or left thoracic curve is there. Then there is in the sagittal plane, from anterior to posterior, there is increased kyphosis or hypokyphosis. Usually the scoliotic curves are hypokyphotic. For example, normal kyphosis of the thoracic spine is 20 to 40 degree, and with scoliosis it goes less than 20 degree. But there may be a hyperkyphotic curves as well, in which there's massive kyphosis, and not only the patient is there is a tilting of the spine, but patient is also bended forward in a very abnormal fashion. Then when you look at from the side angle, then you need to look at what is the problem in the sagittal plane along with the coronal plane. And always remember, you cannot clinically evaluate for the rotation, but there is always rotatory component to this as well. So it's actually a 3D anatomy. The problem in the coronal plane as well as sagittal plane, as well as there is rotation of the spine as well. So you have to assess the alignment. You look at the back, look at from the back, from the side, as well as from the front as a whole. Also assess hip joint, knee and ankle joint. So see if the problem is in the lower limb, which is actually causing a postural scoliosis, as well as assess the shoulders, as well as the nipples and the breast levels as well, because that actually tell you whether the problem is in the upper thoracic spine or is it the problem in the thoracolumbar or lumbar spine. And then you have to see at the skin pigmentation. Why skin pigmentation is important? Because certain syndromic types of scoliosis, for example, neurofibromatosis, they may be present with the cafe au lait spots. So you have to assess whether this is an isolated adolescent idiopathic scoliosis, or is it something which is a syndromic or early onset scoliosis. So to classify it properly, because what you need to understand is when you are dealing with a neuromuscular scoliosis or a syndromic scoliosis, then probably you need to understand that the prognosis will be relatively poor as compared to an idiopathic scoliosis. The curves may be more rigid, they may have a more magnitude, and then they need to be treated more aggressively. So to assess the patient, that what you need to do and how you need to proceed, you need to look at the patient as a whole. Now on physical examination, this is what you see with your history. There will be definitely the things, and then on physical examination you always ask the patients to bend forward, and that is what you have to look for: congenital anomalies, because there may be association with the syndromic scoliosis. There may be other problems. For example, you have to look for Gova sign. The patient may have a Duchenne muscular dystrophy and actually is presenting with the scoliosis now. Then look at the scapular level. Are there any hypoplasia of the scapula or not, or is it actually the scoliosis which is actually causing the scapula to rotate and present at two different levels? Because you need to differentiate from a scapular hypoplasia from scoliosis causing malalignment of the scapula. Then look at the breast and shoulder level, lower limbs length, especially limb length discrepancy causes postural scoliosis that you need to understand. And then the cardiopulmonary function. Why this is important? Most commonly, if you talk about the adolescent idiopathic scoliosis, the most common curve is right thoracic curve. That is, in the coronal plane, the apex is going toward the right, mainly in the thoracic region. But with the juvenile or congenital form, it's usually the left thoracic curve which is more common. When the spine is going towards the left side, that means you have a heart over there, and mainly the lungs gets compromised as well. So sometimes with the large magnitudes of curve, for example, if the left thoracic curve of 70 or 80 degree magnitude, that does have some effect on cardiopulmonary function. So you need to assess this cardiopulmonary function before you move on for any sort of a surgery, because that is eventually gonna actually have a role in a prognosis. If there was a compromised cardiopulmonary function, patient may not have a very good functional life even after a very good radiological surgery, because on X-ray everything looks perfect, but because of the cardiopulmonary compromise, the functional aspect maybe not be that good as it could have been with if the functional cardiopulmonary compromise may not have been present by that time. So whenever you get an history after examination, then you need to go for the imaging. And in orthopedics, the first and foremost we go to is always the X-ray. And we go for the X-ray of the whole spine, that is the thoracic, cervicothoracic, thoracic, thoracolumbar and lumbar spine. So it's a full 36-inch cassette on which you have a full length X-ray of a whole spine, that is the AP as well as the lateral view. We mainly go for PA and lateral view. And if you see it over here, this is what they are actually seeing. You can see it's almost whole of the spine is visible, and you have to look at where the curve is. And the good part is that you have to understand that it should be from the C1 till as lumbosacral junction. Everything should be visible over there. Now you can appreciate over here that there is definitely a right thoracic curve in the thoracic region. Now this is just one form of an X-ray, but we have to make it sure that we have to understand that we have to first diagnose whether is this a structural curve or this is a non-structural curve. For example, when we calculate the curve angle and it comes out to be, let's suppose for this angle it comes out to be 40. Now for any curve more than 25 is usually considered 25, but we have to understand there will be some sort of compensation which will be done to this curve as well. So for example, if it's a right thoracic curve, then we have to get a bending views as well, lateral bending views in which this curve actually partially gets corrected. For example, if it is a right thoracic curve, you have to get bending views towards the right side in which the curves partially get corrected. And if there is another lumbar curve as well, then you have to get left bending views as well so that the lumbar curves gets corrected. Then first we have those in AP and lateral view, then we get those bending views in towards the forward as well as the lateral bending views in the so that we can know how much correction is being done, and then we again calculate the curve angle. For example, if it was 40 and despite the bending view we get is at least the value of 35, but it was 35 for the lumbar curve, but after the bending views comes out to be 20 degrees. So now you understand that we have only to deal with the structural curve. The lumbar curve, we do not need to treat that lumbar curve which is actually now gone below the level of 25 degrees. But if you're talking about a thoracic curve which was initially 40, despite the getting a bending view, it comes down to let's say 30 or 35, then that means still it's a structural curve and you need to do something about it. Now what to do, whether to continue observation, whether to go for form of bracing or whether to go for surgery, I will be discussing later, and how to go about that problem later on. But imaging is not only thing. In imaging it also comes out to be an MRI as well. One thing which you need to remember is that there are specific indications for MRI. Usually if there is a structural problem with the spine, for example, patient may have a syngiomelia, a syndromic scoliosis, in like neurofibromatosis, then you go for an MRI. If normally it's a right thoracic curve, if it's the abnormal curve, for example, if the left thoracic curve, that is also an indication of an MRI. Then usually these curves are hypokyphotic, but if there's a hyperkyphotic curve, then you need to have an MRI as well. So actually there's no absolute indication, but some also say that usually as adolescent idiopathic scoliosis is common in females, even if there's a male child with the left sided thoracic curve, you should also go for MRI as well. But that is something which is not agreed upon by almost everyone. Then again, what type of a curve? If there are more than one or two curves and both are structural, then you may need to have an MRI as well. So in all patients we do not go for MRI, but we have certain set of indications to go for MRI as well. But if it is an early onset juvenile congenital scoliosis, that is, MRI is also an indication that you need to assess for the spine that there is not something wrong with the spinal structures as well or not. And we calculate the curve angle. How do we calculate that? That is after getting the bending views to see how much compensation is being done. If this is the curve, this is with apexes, this is the most upper end and this is the lower end, you draw two lines and calculate a 90 degree to that. This angle is actually will be equivalent to this angle, because sometimes the curves are so large that if you try to meet these two lines, they actually go beyond the film. So what the other option is to get a perpendicular angle, that is the 90 degree angles, and where they meet or bisect each other, that is will be equivalent to this angle. That's how you calculate the curve angle. Once you calculate the curve angle, you know whether this curve is structural or non-structural. If it is structural, then you have to assess other things as well. What is other assessments? Now, other assessments is actually are done to assess whether how much potential for this curve is to progress. Then there are different things which come under that heading, that you have to, on presentation, if it's a structural curve, let's say despite compensation, it came out to be 35 degree curve. Now you know you need to do something about it. Then what the first question which comes to your mind is, what is the age at presentation? Well, if it is usually, if you talk about adolescent idiopathic scoliosis, that is between 10 to 18. But if age is less than 12, that means there will be increased chances of progression. But if a child, a female or a male that comes around 16 to 17 years of age, that means less likely a chance of progression. Then there are certain other things which we need to consider as well, whether the triradiate cartilage is open or not. That usually closes around 8 to 9 years. So if there is an early onset, there will be increased chances of progression. The third most is usually calculated as riser sign. What is the riser sign? We actually calculate the iliac apophysis ossification. Usually the rise, this is what is important to remember, is that riser 0 and 5 appears to be similar on X-ray, because if the whole of the iliac apophysis is not ossified, it will still appear like this, and if it has whole of it as ossified, it will continue to appear as this. So what you need to understand the age of the patient. If it is, let's see, 14 or 15, and you can only appreciate whole of the iliac ala, this means most likely it is riser 5. But the same patient coming with at the age of 6 or 7, this means the patient has a riser 0. Now this is a whole ala is further divided into 4, because less than 25% ossification is riser 1, and 25 to 50 is riser 2, 50 to 75 is riser 3, and 75 to 100 is actually riser 4. So that is how you calculate from riser 0, 1, 2, 3, 4 or riser 5. With the riser 0 or 1, you have increased chances of progression. With the riser 2, 3, 4 or 5, it becomes less chances of progression. That is one way of assessing it. So it's the age, it's actually the triradiate cartilage, it's the riser sign. Third is the Tanner staging, which is more frequently nowadays used because it involves x-rays of the hand, and by which we can actually calculate the peak height velocity. That is exactly how much potential for this child has to grow. If the patient has not attained his peak height velocity, that means there is a potential for child to grow and increase in height. Therefore, this scoliosis curve will progress. If the patient has already attained this peak height velocity, that means now already the progression has occurred and there is less chance of this curve to progress. So once you have assessed the patient, you take the history, take the examination, you calculate the curve angle on the x-ray, especially with compensation. And if you know this is structural curve, then you look at what is the age of the patient, riser sign, what is the peak height velocity, what is the Tanner staging. Tanner staging less than 3 means there will be increased chance of progression. More than 3 means there will be less chance of progression. Once you've done that, then you decide whether this is the curve, whether it's structural or not, or whether it will progress or not. Now that will guide your treatment towards whether you need to go for bracing, or you need to go for surgery, or you need to just leave it alone and observe this. Now this is how it is showing. If you see it clearly over here, this is how much its ossification is occurring. If you can divide all this into 4 parts, this is probably 21, this is riser 0, 1, and this is almost riser 2. The apophysis as yet not ossified completely. Now, when you've done all the imaging, mainly the x-rays, and done the riser staging and the Tanner staging, then you may require an MRI, but usually unless it is a specific indication, you can also go for CT or MRI as well. Once we have done the basic investigation, the radiological investigation, we may have to progress for some special investigations. The special investigations for scoliosis include the function of cardiac as well as the pulmonary function. So you have to go for pulmonary function test. So need to assess what is the status of the patient, whether he or she undergo go anesthesia or not. Then you may need to require a full biochemical investigation. There are all the CP and basic investigations, so that there may be associated with some form of anemia or any other blood problem or not. Then you have to go for neuromuscular investigation as well. If this is not an adolescent idiopathic scoliosis, there may be a syndromic scoliosis, then you may have to go for EMG, NCS and other tests which may confirm the diagnosis. Then the problem is not actually scoliosis, this scoliosis is associated with that syndrome. Therefore, special investigations may be required as well. Some of the patterns which you see this idiopathic scoliosis, this is a young child. If you can appreciate over here, this is a very common right-sided thoracic curve. As with the scoliosis, in adolescent idiopathic scoliosis, the most common curve is always the right-sided curve. If you talk about infantile form is usually present in 4 to 8 years or 9 years of age. Mostly 60% of them are male. There is usually 90% of convex curves which is towards the left side, but in adolescent idiopathic scoliosis most towards the right side. Usually associated with ipsilateral plagiocephaly. That is why the cardiopulmonary detections are very important. It's always a progressive variety because the age is less and they have a high potential to progress. Therefore, most of the time you need to go for surgery. Now, other patterns include adolescent idiopathic scoliosis. Most commonly, there is a right-sided curve, and in 90% of the time, it's the females. Usually, the ratio for adolescent idiopathic scoliosis, female to male ratio is 10:1. That's 10 times more common as compared to the males. Usually, it's 90% are convex to the right, that is the right-sided thoracic curve. There is a rib rotation which exaggerates the deformity because mainly it involves a primary thoracic or bridge thoracic curve, and that is why it's actually very problematic for female children because the rib hump is very prominent in these patients. 50% develops curve greater than 70 degrees, which means this is a structural curve. Even if you cause it to get a right-sided bended view, still this would come around 50 or 60 degree, which would be a very high magnitude curve, so you need to do something about it. Other forms is thoracolumbar curves. Now, one way of classifying is by age. Another way of classifying is by curves, whether it's a thoracic curve, thoracolumbar, or lumbar curve as well. So, a thoracolumbar curve may be isolatedly present or may be associated with adolescent idiopathic scoliosis. So it's slightly more common in females, slightly more common towards right side, and usually features midway between the adolescent and thoracolumbar curve or infantile form. Other patterns may include the lumbar curve only. This may be usually more common in females, mainly towards the left side. Almost in 89% of the cases, it's the left lumbar curve. But in other forms, it may be the right as well. One hip prominent may no ribs to actually accentuate the deformity. In an isolated lumbar deformity, the problem is mainly towards the pelvis, and you can see the tilt of the pelvis, but once the patient bends forward, there may be no rib hump because the thoracic spine is okay, but the lumbar spine is actually having a problem over here. And usually it's not noticed earlier because once it develops over the time, a backache is developed, that is when and that's why with the lumbar curve, the usually patient presents quite late. Other is maybe combined. Now when we have, it could be more than one curve, it could be major thoracic along with the thoracolumbar curve, it could be double thoracic, it could be triple thoracic curve as well, or triple major curve as well. For example, in which upper thoracic as well as thoracolumbar curve is present as well. So therefore, it could be two primary curves, one in each direction. For example, if you see it over here, this is going towards the left is the lumbar, and there may be associated right thoracic curve as well. Then when radiologically it's usually severe and clinically deformity may be more prominent as well. So usually when there is increased magnitude and prominent deformity, these children usually presents early as compared to those with a lumbar problem which are present really late. Therefore, when they are presenting early, then you have to assess the magnitude, assess the peak height velocity, and then assess whether this will progress or not. And then you have to think of it as what is the magnitude, whether I can go for some form of bracing or should I go for surgery straight away. Now, late onset idiopathic scoliosis. This is usually the important point is when the patient presents late. Late means usually from after 12 years. Let's say the female presents by 13 or 14 years because by that time she has achieved her menarche and the growth has actually almost happened. Now when you look at the curve, then there are different usually important thing is that sometimes the patient may present very late, or then if it is early onset, the patient may present very early as well. There may be a marked curvature, and there may be incomplete riser sign in the presentation if it is an early onset scoliosis. But if it's late onset scoliosis, then usually the patient presents late, there may be isolated curve, and it may not be very problematic for the patient as well. Now, how to go about the treatment? As I told you, the treatment depends upon how you categorize a patient. What was the age at presentation? Was it early or late onset? What was the riser sign or tenor sign, which may actually denotes the peak height velocity? Whether it's riser 0, 1 or it's less than or less than 3, this means this is a curve with progress. Or it is 10 or more than 3 and riser 2, 3 or 4 or 5. That means less likely to progress. And then what is the magnitude of the curve? All these actually determine whether you can go for only observation alone. If it is riser, let's say it's riser 4 or 5 and age is around 15 or 16 years of age, and this happens to be a 25 degree or 30 degree curve. Now it's very borderline structural. With age 15, 16, it's already quite late and it will not less likely to progress. Then you can just leave it alone as well. You can ask them to exercise and carry out different musculature exercises, but you can observe as well if this is the case. But if that's the same age, let's say age is 11 or 12 years of age, and she happens to be a riser 0 or 1, and the curve is around, let's see, again 30. Now, although it's borderline structural, it's despite 30, but it's riser 0 or 1, this means there will be increased chances of progression. So if you leave this alone, the patient may progress eventually after 2 to 3 years to riser, may progress to 40 degree curve. So therefore, in that scenario, if it's riser 0, 1, it's structural curve, and there's a potential to grow, and then there is progression, or there is potential of progression of curve, then you can give some form of a brace. Brace could be in form of a Milwaukee brace or a Boston brace. Milwaukee brace is called as CTLSO, that is cervico-thoracic lumbosacral orthosis, and we give it when the curve apex is above the level of T8. When it's T7 and above, you go for CTLSO. And if it is at T8 and below, the curve magnitude is, then you have to go for Boston brace. And Boston brace is called as TLSO, that is thoracolumbar-sacral orthosis. This is when there's riser 0, 1, there is 25 to 30 degree curve, this can progress, therefore you give them some form of brace so they do not progress. But if it curves is more than 45 degrees, it's a high magnitude curve, and this, whatever the riser is, then you will have to go for some form of a surgery because it will not correct with brace or observation alone. And then when we have the high magnitude curve, when straight away go for surgery. For example, if you see this x-ray, you can appreciate, you can see one till sacral or all visible. This is a full 36-inch erect film. What do you see over here? Can you appreciate upper thoracic, as well as right thoracic curve, as well as left lumbar curve as well? Now you will get the bending views as well as the compensatory views as well. And once you get the bending views, you calculate the Cobb angles. If they come out to be structural, which in this case came out probably for a structural curve, let's say it happened to be more than 40-45 degree curve, it was rigid curve, they're straight away gone for posterior spinal fusion, because you cannot leave a large rigid structural curve as such. You cannot just observe it because it's going to progress. The more it's going to progress, the more it's going to compromise the cardiopulmonary function. So then you have to intervene early and go for some form of a surgery. This is an PA view. This is the lateral view. If you can appreciate, the posterior spinal fusion has been done. Now, as with any surgery, there are always complications. The complications could be related to the surgery, or it could be related to the progression of disease. With the progression of disease, the mainly most common important complication could be with the cardiopulmonary compromise, and patient may develop cardiopulmonary insufficiency. But with the surgery, you can have a neurological compromise. There may be certain pedicle screws going in the wrong direction, maybe impinging on the nerve, or the spinal cord may get damaged during the surgery or stretch as well. There may be pseudarthrosis of the cervical or thoracolumbar vertebra. There may be a non-union. Once the non-union develops, there's some form of pseudarthrosis in which there is actually a fibrous union between the two, but there's no callus formation and there's no bony union between them. As a result, there is actually instability and increased movement at that pseudarthrosis site. And then there may be an implant failure as well. There may be breakage of screws, breaking of rods, and instrumentation as well, and which may be due to the increased progression above or below the level of the where the vertebra have been fixed. Then there may be associated back pain or arthritis of that level. For example, if the curve was coming at this level, there may be arthritis of this joint, and maybe arthritis of the joint above and with upper end of the curve as well, and this may result in the back or neck pain as well. Now coming to the early onset or juvenile idiopathic scoliosis. As I told you, broadly we divide into early onset, that is less than 10 years, late onset above 10 years, after 10 years. Usually it's common in 4 to 9 years of age. It is more common in the children, with 60% as almost in the children as well. And again, morely the left thoracic curve is more common compared to the right side. Coming to the congenital scoliosis, by definition classically called as the scoliosis which is present at birth. It is now more of a actually problem due to the failure formation of vertebra. For example, there may be segmented hemivertebra, there may be unsegmented hemivertebra, there may be a congenital bar on one side, and you have a segmented hemivertebra on the other side. When you have segmented hemivertebra, it has a lot of potential to grow, with the one bar on the other side is actually restricting its growth. Therefore, definitely there is a lot of scoliosis formation in that area. And mainly it is always the anterior failure of formation which may lead to hemivertebra formation, and eventually the kyphosis and along with the scoliosis may develop. The less common is failure of segmentation, because they do not segment into different vertebra and there is no intervertebral disc between them. But if there is fully segmented hemivertebra which are not fully formed, they will, as they have been segmented, so they will continue to grow and result in a lot of scoliosis. Now coming to the other neuromuscular, as usually these juvenile form and congenital form are, which include both early onset, are usually syndromic or associated with other causes, such as they may be associated with polymyelitis, cerebral palsy, syringomelia, Friedreich ataxia, lower motor neuron disease, muscular dystrophy, may be associated with neurofibromatosis as well. So commonly, usually when we talk about Duchenne muscular dystrophy, is very common to have associated scoliosis as well. Now, when we are dealing with these neuromuscular scoliosis, what we need to understand this is that usually the curves are multiple. There is large magnitude curves and they are more rigid. So usually we have to go for some, as this early onset means the age of the child is around 5, 6 or 7 years. So when you have a child of a young age which is immature, large magnitude curve, multiple curves with rigid, what the first thing most likely the observation will not be effective, pressing will not be effective. Therefore you have to go for surgery straight away in these kind of situations. Although the incidence is quite low, but when a child does present with these neuromuscular, Duchenne muscular associated scoliosis, then usually the bracing is not effective and you have to go for some form of surgery in neuromuscular scoliosis straight away. So when it comes to scoliosis and neurofibromatosis, if you see this over here, there is a rigid curve of 80 degree and almost a thoracolumbar curve of 52 degrees as well. So now if this is the curve, you need to know that probably it's a rigid curve, so early onset, there is syndromic, and plus there's a structural curve as well. So if you're going to leave it as such, this 80 is going to progress at almost 1 to 2 degrees per year, eventually going above 96 degrees, where it's going to cause death, because eventually the cardiopulmonary compromise is so much that they usually lead to cardiopulmonary insufficiency and death may occur. So that is why in these kind of situations, if child comes to you with this problem at 6 to 7 years or 8 years of age, then you need to do something about it and you need to go straight away for some form of surgery. And as a result, they've done the posterior spinal fusion of thoracic as well as thoracolumbar curve, and after that the curve angle is around 25 and 15 degree, which means it's below the level of a structural curve. Therefore there may be some form of residual scoliosis, but you need to understand that if the residual scoliosis despite surgery is below 25 degrees, that means that is an acceptable form of a surgery and acceptable alignment has been achieved, because sometimes the curve is so rigid that when you try to correct the curve, this results in some other form of a problem. For example, there may be associated spinal cord stretch or spinal cord complete paralysis and complete injury, which is more problematic for the patient, because you have radiologically corrected but functionally the patient may be at a disadvantage. This is another form. This is lateral form in which they have corrected the 70 degree kyphosis. Usually, as I told you, the scoliosis curves are hypokyphotic, but they may be hyperkyphotic as well. In these kind of situation, when you're going for x-rays, you must go for MRI because there are neuromuscular scoliosis. You need to rule out whether there is no structural problem with the spine as well. Along with this, what is the status of spinal cord, as well as what is actually the problem with so much of hyperkyphosis. With posterior spinal fusion, they have not only corrected the scoliosis in the coronal plane, in anterior posterior plane, they've also corrected the kyphosis up to 32 degrees. Normal kyphosis thoracic spine is from 20 to 40 degree. So this 32 degree is well within the normal limits. We have briefly discussed the scoliosis. In summary, what you need to understand is when scoliosis patient comes to you, but there are certain important clinical parameters which you need to assess. The first and foremost is the age of the patient. The second is this: what is the peak height velocity? What is the Tanner staging? What is the riser staging? And whether the triradiate cartilage is open or not. That is important to assess whether what this. Then third is the magnitude of the curve. Whether is it a structural curve or it is a non-structural curve. Now on all these three parameters, you decide whether you need to go for observation alone, you need to go for some form of bracing like Boston or Milwaukee brace, or you need to go for some form of surgery. So if it is less than 25 degrees and it's immature, you need to just observe. If it's 25 to 45 degree curve, which is a structural curve, and there is a riser 0, 1 or 10 or less than 3, then you need to give them brace in form of a Milwaukee or Boston brace. If it is a more than 45 degree curve and it's a structural rigid curve, then you need to go for surgery in form of posterior anterior spinal fusion. Thank you very much. Keep watching sqadia.com.